Hello out there. My name is Dustin Shell. I'll be your MC for today. I want to thank everybody for joining us where we're talking about infection prevention blind spots. What's a leader to do? There's a lot of expectations, a lot of pressure on leader, a lot of responsibilities. And so we wanted to take an angle that was specific to leaders on today's call. And joining me, I've got Dr. Lisa Waldowski, infection prevention expert, and she just brings so much passion and joy to her work. I'm so excited to spend this time with her. But before we do, I want to thank all of the leaders here today. I think there's over 200 of you guys out there. Huge shout out. We are so impressed with how we've seen leaders navigate the past few months. Innovation, perseverance, teamwork, collaboration, like to degrees we haven't seen in a long time in healthcare. So thank you for your service. I know it's hard on your families and also on your teams. So and given that context, like we're all navigating a lot's changing. This is a topic now more than ever, infection prevention. Not just do we need to think differently about it, there's just so much change. There's so much more pressure for people to adhere to these practices when no one's looking, and it takes more people to make it happen. It just felt like a really relevant topic, and with one of the leading experts in the world, literally Lisa Waldowski, wrote the book on some of these standards. We thought, hey, this would be a cool topic to have her kind of like share some of her wisdom with us. And but before I do, just a little bit of housekeeping stuff. I know Lisa's the meat. I'm just like the icing or on the top. So when we get to the Q&A section, we've got a Q&A question here. We would love to hear from you. We've already got a couple in before the webinar started that we'll use, but we've got about a third of the session today dedicated to just answering some of your questions live. Anything we don't get to today, we'll answer on the other side of this in private. And this webinar will also be recorded, so on the other side of this, you can expect a link to watch it and to share it with your team. So with that, let's go ahead and get into it. We've got Lisa here. Lisa, you've got such an interesting background. Infection preventionist, Joint Commission, was literally writing some of these standards, turned to quality leader, then to now consultant, helping organizations. Help us understand what made you make that shift, and then what happened when you did.
Thanks, Dustin, and welcome everyone. I was with the Joint Commission for 5 years, 2013 through 2018, the beginning of 2018 actually. And I had a wonderful 5-year experience with the Joint Commission, educating surveyors, getting on phone calls with organizations. Unfortunately, when I did speak with organizations, it was after their survey or during their survey when there were challenges identified or the survey was looking like it was heading in a adverse decision or a immediate threat to patient health and safety. So I was always looked upon as kind of the bad person with organizations in that light. What turned for me and went into deciding going to an organization to help them during a Joint Commission survey was to switch gears, flip the coin, walk the talk, that much of the material I was sharing with organizations through executive briefings or on phone calls or through emails, I wanted to experience again firsthand, to make a difference or impact or see what the struggles that organizations were encountering, what I could do, and see if I could actually, if my advice was really panning out and I could implement it myself. So I took that opportunity, and plus it was easy for me because the opportunity came up in one of my favorite cities, which many of you may know is New York City. And I had a wonderful 9 months in that organization, of which I will share in a few moments in more detail.
I think that's what's so fascinating and cool about your story is it's one thing to be able to consult and say a thing. It's another to be able to apply it and integrate it and actually like get adoption for it to work in an organization. I think that's why you're so equipped to tell this story and help leaders through their unique situations. As we were prepping for this, you said, Dustin, everybody knows the problems. They're all literally in a book. But there's a difference between those who can actually achieve that culture of safety and those who can't. And I just thought that was interesting. So in your journeys, what have you found to be that difference?
Well, I'll start with a couple of overarching ideas or areas that I see that I'm sure many, or if not all on the call, could readily shake their heads if I could see them out there. That we struggle as a United States country healthcare system with still implementing and systematizing evidence-based guidelines. And obviously this is specific to infection prevention and control areas. So we're not able to, and we've challenged ourselves even further by encountering mergers and acquisitions and making and compounding the issue with trying to systematize and catch up with implementation of these guidelines. In addition, we have methodologies and systems that we have left stagnant. So we constantly hear still today that we've always done it this way, or we haven't seen an infection come out of this process, so why do we have to change it? So moving that dial and crossing that line into new behaviors and a new mentality over that is still a constant struggle that all infection preventionists and leaders, I think, on this call could agree to. And the other piece, and I'm so happy that APIC, the go-to organization for infection preventionists, termed us now. We've evolved since the 1960s, and I know when we first started in infection control with surveillance predominantly, that we've changed our name multiple times, and we now are known as infection preventionists, but we don't practice enough prevention. We are constantly putting out fires and reacting to issues that happen within our organizations in infection control. So being proactive and preventative still is a area that we struggle with on a continual basis. And with those three, quote, blind spots, I want to delve into even further. I don't want this to be a gloom and doom approach to how we want to impact change within infection prevention and control. What makes the difference with a organization, with the leaders in that organization, is cultivating that accountability culturally. I know we always say patient safety and a culture of patient safety, but that goes along with the culpability or accountability piece at the same time to have that patient safety outcome. So included in that means effective communication and a model of accountability to staff. So staff need to see this, again, just as I mentioned why I moved on from the Joint Commission, to walk the talk, to mean what you say verbally, and get away from presenting and instead communicate. So making it real and not having that distance of a presentation and actually having that conversation with the communication efforts that you need to instill in yourself and others. The accountability or overcoming barriers and dealing directly with resistant staff and processes is a huge barrier in infection prevention and control activities and efforts to have successful outcomes. And I constantly want and request and would hope for leadership's best listening and proactive efforts on that behalf. I think finding the issues out is one important step, but taking that further to hold staff accountable and helping remove barriers, whether it be staff in particular or a process in particular, at a system level or at a local level, is critically important. Along with that, inspiring staff. It is so necessary to come forth and be present in an inspiring manner, to get points across, to educate, to mentor, coach, to make change happen, to inspire others to do the good work that they've been hired to do and believe in, is critically important in the successes leadership has on hand to implement what we're discussing today.
I'm struck by how many of those blind spots are related to people. It shouldn't be a surprise. But can you tell me, like, let's make this a little bit more human. I love stories because they kind of they kind of bring focus to something and kind of bring it to life. So tell the story of what you're talking about. Like, bring these blind spots to life. Like, what's a version of this? If I were a leader out there, I'd be curious. What does good look like? Tell me a story about what it looks like for this to show up in the best way.
Okay, so when I took that position after leaving the Joint Commission, this was an organization that was part of a huge system in New York City, and the entire system, minus one of their hospitals that had been surveyed the former year, all were on notice for upcoming survey. So this was a perfect opportunity for me to enter Organization X. And on top of Organization X having to prepare for a upcoming survey, I had the pleasure of working with an outstanding group of individuals that, whether they were frontline staff or in leadership positions, they were open, willing, and ready to hear based on what I surveyed and found on my infection control risk assessment, to listen and implement what needed to happen. We had huge issues with high-level disinfection and sterilization, like many organizations that I have worked with have. And the response was always, show me, Lisa, take me to where this is going on. Let me see it if they weren't familiar with what I was describing. Show me where we need to put a storage cabinet. Show me what room you're talking about to move this process of manual high-level disinfection into. Talk to me more about going to disposable. What are you talking about for this device? It was incredible. I have to say it was a lot of work. It was not by any means easy peasy. I did have a lot of education and a lot of discussion with leaders, but they were willing to take me on, whether it be physicians, whether it be the chief operating officer, who we got in a lot of steps in that organization. We did not sit at the table very often. It was open door, come into my office on a regular basis, but let's walk around and see what you're actually talking about. And I think that was a huge impact for those of us in infection prevention and control. And I know I'm dating myself, but a lot of the newer colleagues that I have met and may be on this phone call or this webinar, you guys take awesome pictures. That was not always the case, that we had our phones and could take pictures, which are just almost as meaningful to get our point across. I unfortunately did not have that opportunity, but this organization was willing to, New York City persons are big walkers, so had no issues with them walking the hospital with me. And we made huge impact with the risk assessment and with our outcome. I know you're dying to know, how did my Joint Commission survey, how did we end this story? We ended this story on a super high note. We had Joint Commission surveyors who came in and found nothing in infection prevention and control, nothing clinically. And the best feedback I got from the surveyor, to include my entire team with, is that she said, Lisa, I have never had so much fun in high-level disinfection, seeing your processes. And not just mine, it was the entire team. We were at a point of hysteria, good hysteria, but knowing our process steps and showing them off. They could not wait for the surveyor to see their process in high-level disinfection. So that was the highest accolade I've ever received on a survey. Not only to have no findings, but to say, Lisa, this was fun. That was a first time for me.
That's incredible. I love the passion you bring to this. I was struck by something different in this story. I'm going to throw you a bit of a curveball here. You started by saying they were ready to listen, ready, willing, and open to listen. And then we went. I could imagine a lot of leaders out there saying, like, I don't have that experience. What is the thing that makes a culture ready and willing to listen? Because I feel like that's a key part of what's going to make an organization successful.
Well, I hate to attribute that the whole goal of this talk is to be prepared for your CMS or your accreditation survey. I do want to say, though, for good or bad purposes, that there was motivation on their part, realistically, to listen, having just come from the Joint Commission and knowing the standards and knowing what were the hot spots or crisis areas that had already happened in their other surveys, because we were the last. Of course, they saved the best for last. How to learn from others. But it was just a perfect timing of being open to listening and learning and implementing. So it was just the timing. And I think, again, from this at a system level, they had also seen what had occurred in their other sites. So I think it just all came together perfectly at that time.
Interesting. And I also know, I mean, you've got a charisma that you bring to this conversation. You also have a set of tools that you use. And you mentioned in one of your blind spot that proactive go see nature of this work, kind of doing an assessment to see what's out there. And I know you have a tool, and we've got one here. We're going to give to participants a sample of a tool we use, a risk assessment. If we could bring that up, I'd love for you to kind of share with the group how you use this tool to not just be, I mean, it seems like something that just kicks off a lot of work and a lot of conversation and a lot of alignment and action in an organization. Orient us to this tool and how you think about it.
Okay, well, first of all, the infection prevention and control risk assessment, which drives the infection control plan, is well known to all of my fellow infection preventionists on the call. What I want to bring to the attention of all of our participants is that this document should be a living document that drives further steps within your organization as they pertain to infection prevention and control. And this document is something that does not just portray a annual review and effort on infection preventionists to fill out, complete, check, done. It has to incorporate what is going on a continual basis in your organization. So, for example, many infection preventionists filled out, and remember, this is an example. You don't have to use this exact form. The content and the activities, where I have the best or most robust discussions with many of my colleagues that I've had even on this phone call, we need to include everything. So you need to have that walk like I had with that chief operating officer at Hospital X in New York City, that you are including your off-site, your new procedures that are infection control related. You get a new sleep center. Dental program is added to your program. COVID-19, I didn't want to bring that up. How long into this webinar before I even mentioned it? Drops in our laps. You finished your risk assessment and plan in January, and there comes COVID in late February, March. Those are the kind of things that have to make us go back to this risk assessment and add to. And I almost want to say, when I was preparing for this discussion and conversation with everyone on this call, regulatory and accreditation is in and of itself a risk. And we don't look upon it as those of us that are in regulatory and accreditation roles don't know any different, but it is a huge risk that we try to prepare for, particularly the year that we're due to be surveyed. But I want to bring this to your attention that this should not be a silo activity that infection prevention and control completes. This should be a document that everyone is familiar with. Your key stakeholders in your organization should weigh in on making sure you've included all, more eyes better, to make sure we've included the kitchen, we've included the pharmacy, we included that off-site sleep center. So we want to make sure that we've also prioritized our risks, because we can't do everything. What are we going to focus on? So Lisa comes to your org and we found major issues with ultrasound surface probes. Well, did you even have that on your risk assessment? Now it's become a priority. We may have to do some shuffling with how high you have placed that, or if you have it at all on your risk assessment. So it's a work in progress, but it's something to have to share with leaders, to show and get feedback and have them weigh in and know all of the areas that you have on this risk assessment. It complements all of the work that infection prevention and control is involved with, which is part of a Joint Commission standard and element of performance, which is inclusive of all activities have to be integrated into infection prevention and control.
You know what I love about this response is, as a consultant, you see a lot of tools. And what's always surprising to me is how much people love tools. There's something cool about having a new tool to use. And the other thing you'll see a lot is that it becomes a thing to do. And what I love, it's like a thing you're done and you're, whew, I did it. It's done. Mm-hmm. What I love about how you're talking about it is it's a platform for conversation and collaboration. It's this thing that brings us together, and it's a reference point for us to continue to use and refine our thinking and our alignment on the work to be done. And so I just love the way you position this thing. It's never about the tool. And so I just love how you position that. Tell me a little bit, you started to hint at it, but tell me a little bit more about how it becomes, you talked in the very beginning about blind spot being proactive, not being proactive enough. Give me some ways that we can use this tool to be more proactive.
Well, I don't know about everyone on this phone, but I have to constantly, to make sure I'm comprehensive and not dropping the ball on an item that may be escalating or we don't know enough about to, quote, truly assess the level of risk, that it's a good comprehensive tool that includes all of your elements, because we're constantly juggling what's the hot spot of the day or the week, or where do we have to put fires out. If we're being proactive, and this is going to lead into a bit of a discussion that I'm going to explain some of our risk areas in further detail, that it should support, this should reflect, this should balance what you're seeing when you're making your rounds and you're doing your tracers in central sterile processing or in endoscopy or out in an offsite clinic with a trophon unit, that those numbers should not be random. They're your numbers, it's your organization that's reflected on that paper. But beyond that, it should mirror where your struggles are. What are, and it should compare to what's everybody across the country. What are surveyors seeing most commonly? Are we the same? Are we a little different? Oh, we don't have dialysis, whatever it may be, but there needs to be some checks and balances to this document to be used in its best capacity.
Awesome. Well, I'm going to switch gears because you started to hint at it, the crisis events and some of that like current reality of leaders, but also, even before COVID, there's lots of crisis events you would see over and over again with the same kind of scenarios playing out. Give us a sense of that. Like, what are some of those high risk scenarios that keep coming up, and what are the blind spots leaders keep missing?
Okay. So whether you term it crisis, hotspots, the many different terms are used. And for those of you that are Joint Commission accredited, and all of us are under CMS, no choice in that it comes as no surprise when you look at what is published by both of those entities, where our hotspots continue to lie. Prior to me leaving the Joint Commission, it was very obvious to me that we were continuing to rise and escalate, and it has not changed since I left, with high-level disinfection and sterilization challenges. You still see reported out hemodialysis, compounding sterile preparations is another one that's IC related. But if you look at 2019, from a Joint Commission standpoint, pre-COVID, and looking obviously at where they were scoring and seeing the most issues or concerns, it still supports organizations paying special attention to ICO 20201 EP2, which is intermediate, high level, and sterilization processes. So minimizing the risk of transmission of medical equipment, devices, and supplies specific to, and we kind of gloss over intermediate levels. So we're talking about hypochlorite, or for lack of another, if you're not into what's that, what's Lisa saying? Bring it down a level, Lisa. I'm talking like bleach wipes, bleach that we may be using in dialysis, or for equipment, maybe certain bladder scanners, some devices per the manufacturer's instructions for use requiring a specific type of wipe. Very important that you realize if you screw up that, you're in that land of a condition level deficiency. When this all is said and done by the end of your survey, may trigger a potential immediate threat to patient health and safety. And CMS is of the same mindset when it comes to these processes with high-level disinfection, sterilization. And I also want to say CMS is particularly interested in the kitchen and has therefore forced the hand of a lot of education that's gone on with the Joint Commission with the kitchen. So the areas for infection prevention and control to weigh in on the risk assessment continue to grow, and they're not low-hanging fruit issues. These are heavy hitters that have a lot of repercussions as to severity on a risk assessment and then on criticality matrices and where surveyors, whether they be CMS, state, or your accreditor, very, very important that you don't want to have numerous findings in those areas.
So if you could go one step further with this, what's a leader to do? You know, we talked about what's a leader to do is literally part of our headline here. You got, you said words like accountability and inspiration and proactive and giving a lot of really cool examples here. Let's switch us to more of that proactive space for leaders. What are they to do?
Leaders need to listen and pay attention to infection prevention and control proactively. So we don't want our colleagues that we work with always being forced that, oh, Lisa's coming with a problem to put out a fire, that we've let it go on too long. Obviously, there are instances where that's unavoidable. You know, the ceiling is leaking and we've had a flood, you know, that wasn't planned for and anticipated. Although I will say we do want to pay particular attention to our aging infrastructure, and we're seeing a lot more with utility issues being critical with water, temperature, humidity, etc. So I don't want to negate or make that sound trivial. But as a leader, I think that going with infection prevention and control routinely with tracers in high-risk areas, to see these processes firsthand, to talk to staff. It's been proven in the literature over time, the more leaders are out on the floor engaged with staff, the more likely they are to bring problems and ask questions to their attention, as opposed to waiting for a occurrence report or incident report to be filled out. And again, we want to prevent that from occurring in the first place. So, you know, the huddles that occur on a routine basis that are brief, but should be orchestrated, that they're purposeful and everyone knows what the intent and the outcome of a huddle or a rounding or tracer.
I think we might have lost Lisa here. I'm going to give her just a second to see if she comes back. Just 1 second, hang out with us. She was just getting in some good stuff here. While she's kind of getting her internet situation figured out, you know, one of the things we were kind of leading into was that, you know, if you want to be seen as a proactive partner to the organization, if you want to create a culture of accountability and safety, if these are the results. So if you could pull up the head, heart, hands visual, like we're a people company, and so many of the blind spots and so many of the challenges that face infection prevention are people related. And so what we know about people is that if we want results, it's easy to stop at the do. That can they do it? Can they swap out the label? Can they follow a process? Yep, they can do it. And we might need to train them to do that. So there might be an education component to that. There might even be a mindset component to that. But when it comes down to, do they believe, do they feel, that is what actually drives the way we think and ultimately the way we act, which gets the results we're looking for. And the thing about shaping the way someone feels or their beliefs is that you have to change their experience. And so to go back to one of Lisa's examples, if you've shown up in the organization for the last 5-10 years as a reactive entity within the organization, or let's say that your rounds, your safety audits are punitive in nature, you start to shape the belief that we need to hide mistakes, or that infection control is not a partner that needs to be at the table for some of these really important conversations. And so if we want to shape the way that people believe about us or shape the way they believe about the work, we have to create new experiences. And I think Lisa's done a really great job of kind of painting a picture and telling us some more stories about how we can shape new experiences to start to shape it. One of my favorite stories, I worked in for a large transportation organization for blowing agents in the airline industry, and when they were working on their culture of safety, and we interviewed lots of blowing agents and leaders, and the common finding was that the people who were consistently adhering to all of the safe practices were someone that either was directly injured, or someone who knew someone very close to them that was injured. And to me, that is an experience, like a very drastic version of an experience that shaped the way they believe, that ultimately shaped the way they think and work. And so, that was a drastic example, but I think it starts to shape. If we want to create a new result, we got to start shaping new experiences that get to new beliefs and actions. So that was my stall, Lisa. I see that you're back. Whew!
My apologies. No, my apologies with some tech issues. Thank you for holding down the fort. So in regards to where I left off, and I apologize for the interruption, what's a leader to do? And I think I was, before I dropped on this call or what have you, having the leaders on the ground with infection prevention and control in huddles, in rounding, and making it meaningful and purposeful, having clear expectations and what outcomes they want to achieve in those opportunities, to see things firsthand and hear from frontline staff, to hear any potential challenges or roadblocks, to implementing activities that have been asked of them or just recently implemented. For example, we've gone through this on multiple occasions with pre-cleaning at point of use throughout many organizations. So that's a perfect example of wanting to see that firsthand demonstrated and asking staff about that process and seeing that it's being effectively implemented.
Totally, and it's another great example of creating that experience of listening, models it to the people so that when they're in that position, they're not meeting it with resistance or fear. They're meeting it with curiosity and a willingness to do something different. And so I just really appreciate that example. Nice, good to see you again, Lisa. We're actually coming to the end here. That was actually the bulk of our content. I'm going to give you one more question, then we're going to get to our Q&A section. We've got lots of good stuff in here. We're going to get to. You do not want me doing Q&A on this session, I promise you. So it's so good Lisa's back. So Lisa, we just had one more kind of just wild card here for you. So in the context of infection prevention, what's a leader to do? Give us like some wisdom, right? You've kind of seen the whole system at play. What's some wisdom for infection control leaders?
I think that you have to be mindful to infection prevention, particularly with now, in addition to pre-COVID, now we're also dealing with a pandemic on top of what we had on our plate prior to that. Now we weren't there yet, and unfortunately that's why it's so crucial to have these infection prevention and control activities and processes in place, that you don't have so many moving parts to prioritize your efforts within an organization, because you never know when that next ball is going to drop in your lap, as we are dealing with currently across the country. So being able and being mindful to refuel and recharge your passion in infection prevention and control. And that's easier said than done. But remembering why you went into infection prevention and control in the first place may be helpful. The other piece is to not go it alone. This is not a practice in isolation. So to have leaders and other key members on your team be supportive and be a go-to. I hope that many of you on this call that I've had the pleasure of working with consider me someone to reach out to. I think it keeps us all on our toes. It keeps us human. It keeps us recognizing what others are encountering, and it can be helpful because if I'm not dealing with what you're dealing with today, I may be dealing with it tomorrow. So we all have very similar issues. I have to say sometimes I always get one-upped by one of you, that it just has a little bit of a twist to it. So that's always good.
That's what keeps things fun, Lisa. You know it. That's like
yes. But inspiring others. I mean, I know it's hard right now to keep your momentum up. I had recently gone to visit my mother, who is a retired nurse, and she wakes up every day and she says, what kind of trouble can I get into? Now, I'm not telling you to get into trouble every day, but I am taking that in a different context to say, when you get up every day, what is your purpose with your job when you go to work? What difference can you make? How can you help one more unit get that transport bin taken care of? Or that one person who still needs that one more, ask that question one more time, and you have the energy and the inspiration to say, yeah, I made a difference. So I want, you know, as much as I think my mom's a rascal, a good rascal, but you know, what can you do each day and not get overwhelmed that this is a incomprehensible process that we're just never going to succeed at. You will. So I just want to impart that we're all in this together and there's support there for you, and we can make a difference and make an impact on positive outcomes and decrease the transmission of infection with our staff and our patients in our environments.
That's awesome. Well, you heard it, guys. What's the leader to do? Get into trouble and inspire people. That's right. I'm quoting you on that, Lisa.
All right.
All right, we're switching into our Q&A section here. We've got a couple questions here. If you haven't had a chance to ask them, go ahead and plop them in. I'm going to start with one around liability first. Okay, so here's the situation. Infection prevention has made some recommendations, regardless of topic, but the hospital administration doesn't act on it. How will it be interpreted by surveyors? You know, any of them, CMS, Joint Commission?
Okay, first of all, a great shout out. Thank you for those who have submitted questions. I love it. Keep them coming. So during survey, they're in both CMS eyes and in Joint Commission eyes and language. The governing body is ultimately accountable for the organization, the practices, processes that are in their domain. So when, for example, there are issues in high-level disinfection and sterilization that rise up to a condition level or a potential immediate threat to patient health and safety, that not only triggers that wonderful infection prevention and control standard and element of performance, but it also triggers a leadership finding and a APR finding, which is part of the accreditation requirement that you are advised in language in the accreditation manual not to be at an immediate threat to patient health or safety in your organization. So those do automatically get triggered. So I guess we're all in this is what I'm saying. So if you're only as good as your weakest link. So if one of us falls, we all go down together. So the ultimate accountability is your governing body, is your leadership, even though at a certain level it looks like, wow, this just falls under infection prevention and control. It does not. So I hope that helps answer that question.
I love that. We all go down together, in it to win it. Here's another question. We got two COVID-related questions, so I'm going to give them to you back to back. So here's one. You've got there's many conflicting reports from CDC, World Health Organization, and others. What governance does survey follow?
So whether your survey is a CMS complaint survey or CMS state survey or Joint Commission survey, if you look at their tracers and look at their content in writing, they are referring to CDC for their evidence-based guidelines and materials. That does not negate that you still have to, because remember, there's a hierarchy in infection prevention and control. You still need to follow FDA law and regulation, OSHA guidelines, which is highest on the totem pole, and then CMS, then manufacturer's instructions for use, then evidence-based guidelines. With COVID, though, which is what this question was asking for, we do still in the United States use CDC guidance for COVID-related activities. And again, with the caveat being any federal law and regulation, any local state regulation that has to do with, for example, sometimes they've been involved with some of the screening and testing and some of the issues related to COVID. That would be your hierarchy that you would follow.
Excellent. This one might be no, this one's gonna be an easy one. I really want someone to stump you in this, for the record. I just want somebody to ask something so hard you're like, I got it, I got nothing. But I think you got this one. Okay, here we go. So have you seen an increase in some of the health-acquired infections during COVID due to bundled care and less trips into the room?
I have not firsthand. Remember, because of COVID, I'm not on site as much as I was prior, pre-COVID. So I have no firsthand knowledge of seeing more healthcare associated infections. Now, remember, many organizations had to dwindle down to just emergent type care, and inpatient care was COVID related. So elective surgeries and what have you were put on hold. Only life or death type of cases were occurring. So I would therefore say, with what we mandatorily or required to report with CAUTIs, CLABSIs, and other National Patient Safety Goal SSIs, your mandatory reporting to National Healthcare Safety Network, and any state requirements that you may have had for reporting, minus the COVID positivity, that we probably saw a decline in our overall HAI, that we would have had a larger population in our hospitals pre-COVID as opposed to COVID cases. Now, with that said, if your COVID cases, which were very high acuity, and they were on ventilators and they were, you know, with Foley catheters, etc., I have not seen the data that would support one way or the other that there was a rise in healthcare associated infections with that transmission piece within the hospital setting. So again, I'm not trying to skirt the issue, but I think, first of all, I saw a lot better use of PPE than I've ever seen with COVID being in hospital settings. Pre-COVID, that was a huge issue with PPE use. So that improved, I think, also because it became scarce. So once things become scarce, everybody wants to use it. But that would be an interesting, actually, that would be a great research question to pursue overall if there was an improvement. I don't think it would be significantly different at this point in time.
Great response. And maybe it was a partial stumping. We can call it that?
We'll
a partial. Okay.
True. Okay.
So here's one about U.S. probes. Is it still recommended that all users have a documented competency for prep, packaging, transport of U.S. probes to HLD sterilization location? And if so, should departmental educators, nurse education assume liability after the initial training, education competency?
Okay, first of all, ultrasound probes, whoever, and I know who said this question, I love it. I absolutely adore the person who submitted this, because this is one of my real passions in life, is surface probes at this point in time. And the competency training and education for a probe process that is under that HLD or high-level disinfection process, yes, you would have to have documented competency and training, starting from the pre-cleaning point of use all the way to storage, like you would similarly to an endoscope. With that said, where that lies as to what we've talked throughout this talk about accountability and leadership and the education component, the training on higher or on initial, I'm going to start doing this process, you would need to have something have educated me. I never have done this before. Now I'm having to do this. I would need to have something in my file that I have been oriented or trained and educated and be demonstrating this transport, this pre-cleaning piece. Whether you have the luxury at this point in time that you have an education department or who you have delegated that to, meaning though that that trainer or that educator has the education and training to do that education and training to others is also the important piece. So yes, it could be an educator. It does need to be someone in your organization, and who that individual is, whether that could be under someone in central sterile processing, that would lie on the resources within the organization on who is the right department or person or entity to do that, because I know there's been a lot of layoffs and a lot of changes within organizations based on resources at this current time, but it could be an educator. But again, then yes, you would hold them accountable to performing that task and having it in their file.
Awesome. Well, we got 2 more questions here. I think we have time for 2 more questions, Lisa. So here's one on HLD traceability. Are all items required to be traced back to the patient, or only flexible scopes and ultrasound probes?
So, excellent question. In regards to being able to prove that you can link a device that has been, it's high-level disinfection. So when you look at your selected evidence-based guidelines, whether they be AORN, whether they be AAMI guidelines, you want to assure if you have to use a device on a patient and it is considered semi-critical, therefore requiring minimally high-level disinfection, your selected evidence-based guideline, that could be a catheter, that could be an endoscope, that could be a probe, that could be a TEE probe. There's many devices that require HLD. And based on your selected evidence-based guidelines, which they all pretty much in a documentation section will state patient name, patient identifier, the scope identifier, to be able to link that device to the patient. So yes, that is pertinent to scopes for sure, and any device that you have to perform high-level disinfection on.
Awesome. Well, I've got one more question for you, and then we'll let these folks go with some goodies. So here's our last question. Will you now change anything on your risk assessment tool to include COVID infection transmission we should consider?
Yes, and to make your life easier, I would strongly encourage putting, like you do, some of your mainstays, like I've mentioned, some of you've heard me say this before, hand hygiene will be on all of our risk assessments till we all retire. So putting a novel pathogen or emerging infectious disease as a placeholder for your risk assessment on a routine basis, and then you can just change it. You know, a few years back it was H1N1, then it was Ebola, now it's COVID-19. You just want to be able to insert that underneath that placeholder, because you could always have something pop up that you don't typically see, and then it's already you've got a place in that risk assessment to add it. But from a survey standpoint, when I go to eyeball your risk assessment for, let's say, this year, I certainly want to see on that risk assessment, because that drove you making changes to your infection control plan, and it changed your prioritization that COVID now became number one on your risk assessment because of the issues at hand. So you'd want to insert that, but you don't want to be starting from scratch or have on a risk assessment every disease there is in the entire world ever from A to Z. You add them as a blanket, generic term, and then you can put specifically what your issues or what your pathogens or what is pertinent to your environment or your setting.
Excellent. Well, Lisa, it is very evident how much you love this work and how passionate you are. So grateful to work with you and also for the wisdom that you've shared with us today. So thank you so much for all of your time and expertise. And for all of you, actually. So I know an hour is a lot right now. You guys have a lot of competing priorities. So thank you for taking the time with us. Super grateful. We have a couple goodies that'll come your way at the other side of this webinar. There'll be the recording, a link to the assessment tool, and the answers to the questions that we were asked here today. So really, really grateful. Thank you, everybody. Stay safe. Have a good day.